welcome everyone to the second session from Women's Children's Hospital, and we have two speakers today who've had a long career in immunisation, but it's obviously been heightened somewhat by the recent last few years of the pandemic. First, we're hearing from Professor Helen Marshall and then Professor Michael Gold. Helen is as well known as Professor of Vaccinology at the Women's Children's Hospital, runs the Virtue Unit, Vaccinology and Immune Research Trials Unit, and has been very active internationally and nationally with COVAX. I'll introduce Mike, I think, after your talk first, Helen, but over to you.
Great. Okay, thanks, Jenny. So I'm going to present on our program of work, which is really about identifying the research gaps in immunisation, doing the research, generating the data, really for change making, for policy and changes in practice. I'd like to pay my respect to the Kaurna people, the custodians of the ancestral lands we gather on today. And just to describe our overarching program, it's Vaccines and Infectious Diseases Group at the Robinson Research Institute within the University of Adelaide. And then, as Jenny mentioned, Virtue, which is the Vaccine and Vaccinology and Immunology Research Trials Unit at the Women's and Children's Hospital. And really our whole aim is about optimising protection against vaccine preventable diseases to reduce death and disability in children. And we have a continuum of research from the basic clinical research, which is mostly around vaccine trials of new vaccines, but also our investigational trials to understand important research questions and policy questions around how vaccines can be improved. And then a more epidemiological approach around evaluating vaccine programs once they're introduced into a population, and then about improving vaccine program effectiveness, which is very much about improving access and equity to vaccines, which is really the main reason why people don't get vaccinated. So within the vaccine clinical trials, I'll just give you a couple of examples at the moment. We are undertaking a RSV vaccine trial in pregnancy. This is a phase 3 trial that is funded by Pfizer and is very close to likely to be available in the future to protect infants against bronchiolitis. Pertussis nasal spray vaccine, so obviously using a nasal device, spray device is nicer than having an injection, but there's also a potential benefit there that we get protection against infection of the bacteria as well as protection against systemic disease. And then our investigator-led research, just a couple of examples. So we have MRFF funding, and you'll see there in yellow, I've kind of included the partners, and then in green, the methodology, because I know that's the focus of the presentation today. So with TKI and the National Centre for Immunisation Research and Surveillance, we're doing a study of a phase 1 Covalia study, which is a DNA COVID vaccine. Peekaboo, which I think is a great name for a study, is also funded by the MRFF and is looking at which is the best booster COVID vaccine for use here in Australia. So randomising people to 3 different COVID vaccines. And then we're very interested in the impact of certain conditions on vaccine responses. So we do a lot of work around impact of pregnancy, obesity and the microbiome in collaboration with the Lin Lab at SAMRI. And you'll see there we use methodologies such as clinical randomised controlled trials, observational studies such as cohort and case control methodologies. And then you'll see a whole list of laboratory partners around microbiology and the serology and the immunology that supports the investigator-led research work there. And in evaluating vaccine programs, hopefully you've all heard of the Be Part of It study. It was undertaken here in South Australia, enrolling 35,000 young people to look at impact of the MenB vaccine if you roll it out to adolescents on carriage. We've also now taken that study to the Northern Territory, which is funded by the National Health and Medical Research Council, to look at the cross-protection this vaccine could provide against gonorrhea, as both those bacteria from the same family and preliminary evidence from other countries has shown this potential impact. And then we undertook an evaluation of the South Australian MenB program here in South Australia. And we have a paediatric active enhanced disease surveillance project, which is funded by Commonwealth government, looking at vaccine preventable diseases and looking at that severe end of the spectrum where children are hospitalised with conditions that are potentially vaccine preventable. And again, methodologies around clinical trials and cohort and case control studies and using test negative design in our case control studies. The third component around the improving vaccine program effectiveness, as I mentioned, is really a focus on access and equity. And just to give an example of that, we've had NHMRC funding to look at nudges, how you can actually improve immunisation uptake in special risk groups such as pregnant women and medically at risk children who are clients here obviously at the Women's and Children's Hospital, developing nudges that and a nudge is really a way to improve health behaviour, and we see immunisation as an important health behaviour that we hope to enhance uptake of. So you'll see there an example of one of our nudges on. And again, we use mixed methods, qualitative and quantitative, and then we will test those interventions in a randomised controlled trial to evaluate them. And translational outcomes are really important for our body of research, and we've had data provided for licensing of vaccines on the National Immunisation Program here in Australia and overseas. We're contributing that data. The MenB, just to give an example, in our evaluation of the South Australian program here, we showed impact on meningococcal disease and gonorrhea, and we've just heard the Czech Republic are going to introduce MenB vaccine based on our recently published Lancet Infectious Diseases paper. We've also been working with SA Health around access and equity, and I was able to provide the evidence for targeted programs for disadvantaged groups such as homeless people in South Australia. Of course, I don't do all this alone. I have a fabulous team, 22 of us, doctors, nurses, scientists and laboratory technicians, 8 leaders within my group, covering all the important components of the work that I've just run through around the clinical trials, but also the epidemiology and evaluation. And just if you're interested in our structure, we have weekly meetings to really make sure that what we're research does end up being published, and also support for ideas around projects and training, and working with Salen and Nalan to improve the capacity for clinical trials in paediatrics and obstetrics. And our partners and my contact details. And I'll leave it there, Jenny. Very happy to take any questions.
I mean, it's been a great story, Helen, from the MenB studies that it's exploding into, and then the pandemic coming. And but as we all know, some of the things that we discover is the ones that are most out there are often not the ones we're sort of almost most proud of in a way. Yeah. You sort of recognise that some things that are sort of quieter, done more different. So are you happy to think about, of all the things, all the projects you've done over the last 10 years, which one is sort of most precious to you in a way?
Yeah, look, I think that the MenB carriage study, just because of the size of it and also the partnerships and collaboration and a lot of excitement in the community, in the schools about being involved in research. So we've taken kind of the learnings from that to the Northern Territory. But having said that, obviously the Northern Territory is a very different environment. So again, to me, it's about, it's about the collaboration, but it's what we learn from other people that I guess strengthens and makes our research really interesting. And so working with Aboriginal people in remote communities and having very different messaging around the study, and a very different way of setting up a clinical trial when you're trying to cover the whole of the Northern Territory, from Darwin, Alice Springs and out into remote communities. So incredible, a lot. It's probably the most effort and energy I've ever put into anything, I would say, because we had to deal with COVID at the same time and communities being closed so that we couldn't go into them, schools being locked down. It's been incredibly challenging, but I think that's where you learn a lot about research and problem solving.
Great, thank you very much. So on that note, we'll move on now just to Mike. So Professor Michael Gold works well with Helen because he is also international renowned in the area of vaccinology, particularly in vaccine surveillance and safety. He's a paediatric immunologist and allergist who headed the Department of Women's Children's Hospital for some years until recently, and has recently been working more with has worked with WHO for some time, but particularly recently in the COVID pandemic has been involved very much in Southeast Asia vaccine surveillance and safety. Over to you, Mike.
Thanks, Jenny. Can I confirm you can hear me and see my screen?
Oh, that's good. Yep, all good.
Okay, great. Look, thanks for the invitation, and thanks to Helen for the presentation. I'm going to take a slightly different tack, but for those online, I suppose I want to give you really a view that what you do locally can have a global kind of impact. So I'm not going to talk very specifically about the vaccine research. I don't do vaccine clinical trials because that's a conflict with me with vaccine safety. I'll talk a little bit about the allergy trials that we do though. So let me just go to the next slide. Seem to move. Okay, great. That's not obscured by anything, is it? You can see that. So look, what I'm going to talk about is, as I said, lastly, the vaccine, because of the vaccine meeting, but I just wanted to mention in passing that within our department, we do clinical trials largely regarding food allergy prevention and treatment. Multiple collaborators. These are my contact details. And if anyone wants to know more about that, then contact me directly. But this kind of gives you a flavor of what we do in the allergy field. And as I say, I'm just passing on this because I'm going to move on to the vaccine shortly. So we're doing a large NHMRC funded study in terms of maternal ingestion of egg and peanut, in terms of preventing egg and peanut allergy. There's a case cohort study looking at wholesale pertussis vaccination to prevent IG-mediated food allergy. There's a treatment study looking at oral immunotherapy with peanut and probiotics, which has been completed, and we're in a long-term follow-up study for that. And then I'll just mention in passing the 3 industry studies we're doing, just to give you a flavor, all to do with, at least 2 to do with treatment of peanut allergy. One is using a peanut impregnant patch to prevent peanut allergy or to treat it. The other is using monoclonal antibody treatment to block allergy reactions to peanut. And the last is a primary prevention study looking at gut bacteria. So that just gives you a kind of flavor of the allergy side. And as per Helen as well, looking at RCTs mainly. But I want to get onto the vaccine stuff, and I want to give you a sort of overview of what my involvement with WHO has been, only because that I think would be interesting for you. So I'm going to talk about vaccine safety, and obviously vaccine safety has been a concern since the first cowpox vaccine was used, and this is a cartoon going back to 1796. I'm going to talk about adverse events following immunization, vaccine reactions, and various collaborations really with WHO and international collaborators, and how this was translated through the pandemic. I'm going to give you, I think, 4 or 5 quotes from Shakespeare. The first one, what's in a name? That which we call a rose by any name could smell as sweet. So case definitions for adverse events are very important. And this really describes what the adverse events are. The Brighton Collaboration is a group of researchers that really have got together for decades to really formulate case definitions for adverse events. The first one one of the first that was formulated was the anaphylaxis one. This was in 2007. And this was really to describe and to bring some standardization into describing these adverse events after immunization. This is the citation of that anaphylaxis paper. And as you can see, not very well cited until the last 2 years. So really what happened in the last 2 years? Well, we know what happened. This was COVID. So essentially the first COVID vaccine was given on the 8th of December 2020. On the 9th of December, essentially because of reporting of allergy reactions thought to be anaphylaxis, it essentially was a major vaccine safety signal to investigate at the time. And if you remember back to that, there was a lot of concern about allergy reactions at the time. This is data from the US showing that the anaphylaxis rates as reported were probably 10 to 100 times greater than we would have expected. Now through time, we've shown that that's in fact rate is much lower than that. But what this led to really, and this is what I want to come onto, is really a lot of debate around that case definition. So what's in a name and what's in a definition is very important. And really how you define anaphylaxis, which is a clinical syndrome, can obviously influence the way that you may look at rates of anaphylaxis after vaccination. So I've been involved in an international group which has now looked at revising the case definition for anaphylaxis. And the issues are that when the original case definition for anaphylaxis was formulated, this was largely for pediatric setting and not for adolescents and adults. So presentations of anaphylaxis are different in adults and adolescents. There are lots of mimics of anaphylaxis. There are issues around application of the case definition, and there are issues around reporting of subjective symptoms. So to finish off then, this is the revision of the anaphylaxis case definition. Again, sort of illustrating how important international collaborations are, and how this does lead to research opportunities and will need to lead to research opportunities in regard to evaluating this case definition. The second issue that I want to cover is death. So death as an adverse event following immunization is very uncommon and very rare, as we know. So death, a necessary end, will come when it will come. There are very few ways that a vaccine can actually result in death. So the causes are essentially limited to what we call vaccine product reactions, which is what is in the vaccine, or immunization errors. And this is something that we investigated through WHO going back to 2016, was really to define what the causes of death were following vaccination, and very few, in other words. So this then leads us obviously to the AZ vaccine and the thrombosis with thrombocytopenia syndrome, which I can't go into, but obviously had a lot of coverage through the lay media. And this really highlights to me a very, very rare obviously reaction to this particular vaccine. It was almost a unique syndrome related to it, and as you can understand, led to a lot of concern within Australia and a withdrawal of the AZ vaccine, both in Australia but from many high-income countries. And the interesting thing is that, of course, the AZ vaccine in low and middle income countries is the predominant vaccine that was used and is still used today. So you can see within the Southeast Asia region, 74% of people in terms of getting a COVID vaccine would have got a viral vector vaccine. And this obviously creates a huge issue. If it's not used in high income countries, what do we do in low income countries? So again, illustrating collaborative work done with the WHO to formulate really guidelines for clinical case management of TTS, because it became very important for us to know that the condition could be recognized and obviously managed within a low resource setting. So this is an excellent document and really summarizes it. Is something that I had input into both within the original guideline, but also subsequently. The interesting thing is that rates of TTS reported within low-income countries is very low. If you see the reporting within Southeast Asia, you've got 0.29 per million doses, whereas you can see the rate for other countries, including Australia. Again, leading to research opportunities for us to understand whether this is just a pure reporting and surveillance issue, or whether it relates to, in fact, a lower incidence of this adverse vaccine reaction. The third kind of area I want to get on and to sort of illustrate is issues of causality. So again, a quote from Shakespeare around cause and really finding out the cause of the effect. And it's just differentiating an adverse event from a vaccine reaction. So if something bad happens after a vaccine, we call this an adverse event following immunization. And it's important for us to differentiate an adverse reaction from a coincidental event. At WHO, we've been involved in developing a very specific tool to use in order to differentiate the reaction from a coincidental event. And in terms of translation, this tool is now being used really globally for all serious cases that are reported through surveillance systems in order to differentiate this reaction from a coincidental event. So again, a resource just illustrating for you. And the next major area that I just want to sort of cover is the issue of immunization stress-related responses after adverse events. And here's another quote from Shakespeare. And again, this in the olden days would have been called hysteria, but the reason why it's important to vaccination is that with mass campaigns, and we know that obviously COVID vaccination was a mass campaign, that these mass hysteria events or mass stress-related responses can present in many bizarre ways and can disrupt immunization programs extensively. So the WHO in 2020 published this document. I led a group that developed these guidelines and published on this to really make it aware to vaccine program managers and to people who were implementing immunization programs that this was an entity that could present. It was related to the process of immunization, not what was actually in the vaccine. And that it could lead, if not recognized and managed from a communication point of view and clearly, to these mass events. And indeed, in Thailand, one of the countries that we look after through the Southeast Asian region in WHO, there was one of these mass events at the beginning of their program, and fortunately was well recognized and well managed, and they were able to continue with implementing their vaccine program. And this is just a breakdown of serious adverse events in the Southeast Asia region. And you can see that 24% of those, of the 3,000, fall within this particular category of adverse event classification. So a real issue for countries in terms of mass campaigns. And then the last area of interest and research is occurring locally here at the Women's and Children's Hospital. And this concerns the cardiac adverse events or adverse reactions after mRNA vaccines. And this you would have heard, and you'll be familiar with this through lay reporting. And of course, that the extreme end of this is myocarditis after either Pfizer or Moderna. And again, the rates here are for you to see. The study we're doing at the Women's and Children's Hospital really is looking at all kids who present with chest symptoms. And I've just got one slide on this to present to you. And this just shows that in all, we've had 111 presentations through our emergency department, that really a quarter of those are myocarditis, but more puzzlingly, 3/4 of those do not have the markers of myocarditis and yet do have marked chest symptoms, whether this be chest pain or shortness of breath. You can see the age distribution, which obviously reflects the referral pattern to our hospital. You can see the gender distribution in terms of the non-myocarditis cases compared to the myocarditis. And you can see that it's largely a female predominance as opposed to a male predominance within the myocarditis group. So I'm just, that is the completion of the talk. And I just wanted to illustrate for you really that endeavors that we've done locally in contributing to WHO through international collaborations have led to a lot of really very useful tools for use globally in terms of both the management, the detection of adverse events, but also their management. And I hope I've not gone too much over time. Thanks very much, and I'll stop sharing the screen.
Thanks, Mike. And we've got some questions. It was a fascinating talk. I love your quotes too. Is there, first question from an anonymous questioner, is there auditing of the WHO vaccine adverse reaction data, especially in the third world, and how this is achieved, which I think you probably know quite a lot about?
Yes, okay. So look, the adverse event data is for most countries collected within the country. And the majority of countries submit that data to the UMC database, which is the sort of centralized global database of adverse events. In terms of serious adverse events, each country is asked to perform causality assessment as per the schema I showed you. And I guess that's where we differentiate an adverse event from a reaction. So the auditing is really occurring within countries. In terms of the auditing within a global context, it's really high level looking at surveillance data and looking for vaccine signals at a global level. So if I understand the question correctly, I would have to say that adverse event data is, or vaccine reaction data is largely audited within countries. It's largely the regulator, the NRAs, which are similar to our TGAs in terms of auditing that. John, if Jenny, I can just read it off here. John has asked about, John has asked about vaccine-associated myocarditis. John, look, we did have access to Medicare funding to do cardiac MRIs. By and large, we haven't done a lot of cardiac MRIs to look closely at the myocarditis. The diagnosis is largely, again, made according to filling a case definition. And again, this comes back to the Brighton Collaboration in my talk about case definitions. I spoke about anaphylaxis, but there is a case definition, as you would well know, for myocarditis as per Brighton, but obviously there are other case definitions. So we largely make the diagnosis on a troponin, on ECG changes, on inflammatory markers, and on symptoms. The cardiac, I've yet to see an abnormal cardiac MRI in the ones that we've done here through the Women's and Children's. And I would say that generally, if we look at the group that have presented with chest pain to the Women's and Children's Hospital, the ones with myocarditis are generally the easy ones. They tend to respond to anti-inflammatories. They tend to respond to paracetamol, but it's this non-myocarditis group that I showed you that in fact form the majority, 3/4, that are much more puzzling to answer in terms of what the cause of those chest symptoms are. And if anyone online has any ideas, please get hold of me to really understand that group. But at the moment, we're really just trying to define the phenotype of that group. And then I can see one from Alexia about under 5 and myocarditis. So basically, with myocarditis, which is vaccine related, we seem to be having the highest rates, obviously between 18 and 24. Now, having said that, of course, we know nothing about adverse events and adverse reactions in the kids 6 months of age to 5 years of age. We know very little about that group. And this is going to depend on post-licensure surveillance when you're really immunizing lots of kids in that group. So no, Alexia, we don't know a lot about that.
Great. Well, that was a rapid but very informative review. And oh my gosh, the last 2 years have been so important to have these types of experts. So thank you very much, Helen and Mike. I really enjoyed that. So thank you very much indeed. And to our attendees and their questions.
Thanks, Jenny.
Thank you. Thanks.